discussing the cardiac physiology. First of all, we will discuss the heart volumes. What are heart volumes? There are two types of heart volumes, that is the end diastolic volume and end systolic volume. What is end diastolic volume? We all know that this is, for example, a heart. This is the right atrium. This is the left atrium. This is the right ventricle. And this is the left ventricle. Now, we all know that through superior vena cava and inferior vena cava, the blood will come to this right atrium. And from this right atrium, it will then come to the right ventricle. And from right ventricle, the blood will come to the pulmonary circuit, that is the pulmonary artery, and it will come to the lungs for oxygenation purposes. So this is the lungs where the blood will be oxygenated. After it gets oxygenated, it will come to the left atrium. And from left atrium, the blood will come to the left ventricle. Now, when the left ventricle is receiving the blood, it relaxes. Let's suppose this is the left ventricle and it is receiving the blood from the left atrium. So during this phase, this left ventricle will be in a state of relaxation. Now here the volume of blood will be present. End diastolic volume. End diastolic volume. That is the volume of blood which is present in the left ventricle at the end of diastole. So this is the end diastolic volume. That is, it is present when the filling is completed. And this volume is present when the ventricle is about to contract. After the end diastolic volume, it has reached to its maximum level. So then the left ventricle will start contraction. That is the beginning of the contraction will occur at this point. Hence, the volume which is present at the end of diastole is known as end diastolic volume. The second concept is of end systolic volume. So what is end systolic volume? When this ventricle contracts, this is the ventricle. When it contracts, it pour the blood into the aorta. So the blood is poured into the aorta, while the volume which is present at the end of systole, that is when the blood is poured into the aorta, still there is some volume which is present, and that volume is called end systolic volume. That is, emptying is completed. So left ventricle is emptied, means most of the blood has been poured into the aorta and relaxation is beginning. Behind this point, the relaxation will begin. Okay. Now let's discuss some of the important terms. The term stroke volume, the term ejection fraction, and the term cardiac output. What is the stroke volume? So the stroke volume is the volume that is obtained from the subtraction of end diastolic volume from the end systolic volume. Again, here is the left ventricle, and this left ventricle is relaxed at maximum relaxation state. It is represented over here. So here the volume is present, and this volume is known as end diastolic volume. Here the ventricle is in the state of contraction, that is the systole. And here some of the volume of blood is present. Obviously, there are more blood present in this state as the heart is relaxed at this state. And here the blood volume is less because the ventricles are contracted. Now, the stroke volume is the volume which has been ejected to the aorta. So this is the aorta, and the volume which is present in this aorta after one beat. So this is known as stroke volume. So how we will get it? When we subtract this volume from this volume, so we will get this volume. So that's a simple mathematics. The end diastolic volume minus end systolic volume, and we will get the stroke volume. Now the ejection fraction. What is ejection fraction? So in order to get the ejection fraction, we divide the stroke volume by end diastolic volume. Again, ventricles in the state of diastole. Okay, so here this is the volume of blood, and we call it end diastolic volume. How much of this blood has been ejected? How much of this blood has been ejected? So if we calculate it like this, the stroke volume divided by EGV, so we will get that this much fraction of end diastolic volume has been ejected. And that fraction which has been ejected is known as ejection fraction. Now we know from the previous discussion that stroke volume is equal to end diastolic volume minus end systolic volume. So if we put this equation in this, so we can get that ejection fraction will be equal to end diastolic volume minus end systolic volume divided by end diastolic volume. That is, the fraction of the end diastolic volume which has been ejected is known as ejection fraction. The third thing is cardiac output, which is equal stroke volume multiplied by heart rate. So cardiac output is the number of beats per minute and the volume of blood ejected per beat. So basically, the cardiac output tell us that how much liter or milliliter of blood has been ejected per minute. It gives the volume of blood coming out of the heart per minute. So this is called cardiac output. Venous return. Venous return is a blood return to the left ventricle, and it should be equal to the cardiac output. Now, how does this venous return come to the left ventricle? The blood comes to the right atrium, and from right atrium it goes into the right ventricle, from right ventricle into the lungs, and from lungs into the left atrium, and eventually into the left ventricle. So eventually this comes to the left ventricle, and this return of the blood which eventually goes into the left ventricle should be equal to the cardiac output. That is the amount of blood which is ejected from the left ventricle during 1 minute. So this venous return and the cardiac output should be equal for normal physiological function. The second thing is total peripheral resistance. Now, what is total peripheral resistance? This is the resistance to the blood flow from peripheral structure. So the blood is, let's suppose this is the ventricle, the blood will flow in this direction. That is from the aorta and available into the arteries and into the arterioles. So the peripheral structures, which is offering a resistance to this flow, the resistance offered by these arterioles, arteries, and these structures to this flow of the blood is known as total peripheral resistance. When the vessels are constructed, let's suppose these vessels are constricted, so the total peripheral resistance will increase. When these vessels are dilated, so the blood will go easily and the total peripheral resistance is decreased. We will discuss some of the blood pressure terms. That is the systolic blood pressure, diastolic blood pressure. What is systolic blood pressure? This is the blood pressure present in the arteries when the heart is in a state of contraction. And diastolic blood pressure is the blood pressure present in the arteries when the heart is in the state of relaxation. So during diastole of the heart, the pressure measured in the arteries is known as diastolic blood pressure, and the blood pressure measured in the arteries when the heart is in the state of contraction or when the heart is in the state of systole. That is known as systolic blood pressure. The systolic blood pressure is largely determined by the stroke volume. So if the stroke volume is increased, so the systolic blood pressure will rise. And in diastolic blood pressure, it is majorly determined by the peripheral resistance. If the peripheral resistance is high, the diastolic blood pressure will be high. But if the peripheral resistance is low, the diastolic blood pressure will be low. And the systolic blood pressure, it is determined by the stroke volume. So if the stroke volume is high, the systolic blood pressure will high. If the stroke volume is low, the systolic blood pressure will be low. Now what is pulse pressure? The difference between the systolic blood pressure and diastolic blood pressure is known as pulse pressure. This is the pulse pressure. And it is proportional to the stroke volume. That is, if the stroke volume is increased, systolic blood pressure will be increased. If the systolic blood pressure is increased, so the pulse pressure will increase. How? Because pulse pressure, as we know, is equal systolic blood pressure minus diastolic blood pressure. Let's suppose initially the systolic blood pressure is 120 and the diastolic blood pressure is 80. So the pulse pressure will be 120 minus 80 equal 40. But if this systolic blood pressure is raised, let's suppose to the 140 and the diastolic blood pressure is still 80. So here the pulse pressure will be 60. And we also know that systolic blood pressure is largely determined by the stroke volume. That is, this systolic blood pressure will be raised if the stroke volume is raised. If the stroke volume is raised, so systolic blood pressure will be raised. And hence, the pulse pressure will raise. Now, what is mean arterial pressure? Mean arterial pressure or MAP, it is equal to the diastolic blood pressure plus 1/3 of pulse pressure. We also know that this is diastolic blood pressure plus 1/3 of pulse pressure. We also know that the pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. So here you can see that diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. For example, if a patient is having BP of 120 by 80, so here we need to calculate the mean arterial pressure. So how we will calculate the mean arterial pressure? We will calculate the mean arterial pressure as the diastolic blood pressure is 80, so 80 plus 1/3 of pulse pressure. 80 plus 1/3 of the pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. So what is the systolic blood pressure? It is 120. And what is the diastolic blood pressure? It is the 80. So here 80 plus 1/3 of 40, and here it will come 93.3. So this is the mean arterial pressure, and that's how we calculate the mean arterial pressure. Now let's discuss the cardiac output. We know that cardiac output is equal stroke volume multiplied by heart rate. In other words, we can say that cardiac output is the volume of blood ejected from the left ventricle per minute. Okay, so this is very important physiological parameter. Must tries to meet demand. The more cardiac output means the more work the heart will do and the more oxygen it will consume. The cardiac output is equal to heart rate multiplied by stroke volume. More beats per minute means more work by the heart, and more volume per beats means more work by the heart. So, if the heart is ejecting more volume, that means the heart has to work more, and hence the cardiac output will increase. If there is more beats of the heart, still the cardiac output will rise, and for more beats, the heart will have to work more. In terms of the cardiac output are preload, afterload, contractility, and heart rate. Preload is basically the amount of blood located in the left ventricle. Now this is the heart, left ventricle, and here the amount of blood is present before the contraction, which is called end-diastolic volume. And because of this end-diastolic volume, the load it is applying on the heart wall is known as preload. That is before the contraction. So free load. More preload means more cardiac output. If there is more preload, means the heart will contract more, and if the heart contracts more, so the more blood will come out, and there will be more cardiac output. More preload means more work the heart must do, and for that work, it will require more oxygen. The stretch and the fibers prior to the contraction. It is denoting this pressure which is applying this volume of blood on the walls of the left ventricle. And before contracting, this force or this stretch has been applied on the left ventricle, and in response to that stretch or length, the heart will contract more. And that contraction will eject the blood from the left ventricle into the aorta. Now how this preload will increase? If we add volume, so there will be increased volume in the left ventricle, and that increased volume in the left ventricle will increase the preload. And how we can increase this volume? By giving blood or intravenous fluids, by decreasing the heart rate. So if the heart rate is decreased, there will be more time for the left ventricle to fill from the blood. And the third thing is constrict veins. That is, if the veins are constricted, and because of this constriction, more blood will come to the left ventricle, And if the more blood is coming to the left ventricle, it will apply more stretch on the walls of the left ventricle and it will increase the preload. This venous constriction is in response to blood loss and is because of the sympathetic stimulation of the alpha 1 receptors present in the blood vessels. To decrease preload, we need to remove the blood, that is, through bleeding, dehydration. So, if the blood is removed, there will be less blood in the left ventricle and hence less preload. We need to raise the heart rate. If the heart rate is raised, so there will be less time for the ventricles to fill and hence the preload will be decreased. And the third thing is pool blood in veins. Let's suppose if we give nitrates to a patient, it will dilate the veins. So if the veins are dilated, there will be more blood in the veins. So if the blood is pooled in the veins, so it will not come to the left ventricle eventually, and hence the preload will be decreased. The angina is reduced by this mechanism because when we give nitrates to a patient, it causes vasodilation of the veins, and that lowers the preload. And when the preload is lowered, the heart will need less work for the contraction. That is, if there is more blood in this left ventricle and it applies more stretch on the walls of the ventricle, the heart has to contract more forcefully in order to eject the blood. But if there is a less volume of blood present in this left ventricle, so it will apply less stretch on the walls of the left ventricle, and eventually there will be less work for the heart to eject the volume of blood into the aorta. Here are some terminologies which are equivalent to preload. That is the left ventricular end diastolic volume. The volume of blood in the left ventricle when the ventricle is filled. Okay, and practically this volume measurement is almost impossible and it is very hard to determine this volume. So practically we use the left ventricular end diastolic pressure. That is the pressure in the left ventricle when the ventricles are filled. So these are the ventricles in the state of diastole. Here is a volume of blood which is present, and here is a pressure applied by this volume. So we can measure this pressure, but we cannot measure the volume practically. That's why we often use this left ventricular end diastolic pressure. Now, what is afterload? Afterload, now the force is resisting flow out of the left ventricle. So let's suppose this is left ventricle and the blood is coming out through aorta. Now, the forces which are resisting this outflow of blood, this outflow of blood is resisted by some forces and that we call afterload. The heart muscle must squeeze to increase pressure. These heart muscles need to squeeze in order to eject the blood from the left ventricle into the aorta. And because of this pressure, the aortic valve will open and the blood will push into the aorta. Now, this is harder if the blood pressure is high over here. So, the heart will need more pressure in order to get blood into the aorta because here is pressure in opposite direction. And let's make the afterload increase. The second thing is if the aortic valve is stiff. The stiffened aortic valve will also increase the resisting forces to the flow of this blood, and hence the afterload will be increased. And if there is something in the way, like hypertrophic cardiomyopathy or subaortic membrane, so whenever there is resistance to the flow, the afterload will increase. To increase afterload, raise mean arterial blood pressure. That is when the MAP is raised, so the afterload is increased. Or the outflow of the left ventricle when it is obstructed. So, like in aortic stenosis and hypertrophic cardiomyopathy. And to decrease the outer load, we need to lower the mean arterial pressure and treatment of the aortic valve disease and hypertrophic cardiomyopathy. When there is more outer load, the heart will do more work and it will need more oxygen. Now the third thing is contractility. So let's discuss the contractility. Contractility means how hard the heart muscle squeezes. The ejection fraction is the index of the contractility. When there is more contractility, there will be more ejection fraction. That is the fraction of the end-diastolic volume which will be ejected into the aorta. The major regulators are the sympathetic nervous system because it increases the heart rate and it also increases the contractility. So when the sympathetic nervous system is activated, it will increase the contractility and also it will increase the heart rate. To increase the contractility, the sympathetic nervous system is responsible for it. The sympathetic innervations are into the heart, and there are circulating catecholamines like epinephrine and norepinephrine. These epinephrine and norepinephrine's will act on the beta 1 receptors present in the heart, and it will increase the calcium release from the sarcoplasmic reticulum in the myocytes. The physiological stress for this sympathetic nervous system activation are stress and exercise, while the pharmacological drugs are dopamine, dobutamine, epinephrine, and norepinephrine. Digoxin can also increase the contractility, and its mechanism of action is that it inhibits the sodium potassium pump and it increases the calcium in the myocytes. To decrease the contractility, the sympathetic nervous system blocking drugs might be used, like the beta blockers. So, what does the beta blockers do? It will block the beta receptors, and beta 1 receptor is present on the heart. So, when it is blocked, then there will be decrease in contractility of the myocytes or eventually of the heart. Calcium channel blockers, and these are the calcium channel blockers which acts on the heart or myocytes. That is the cells of the heart. What are those calcium channel blockers? These are two, verapamil and deltazine. Because there will be less calcium for muscular contraction. For which muscles? For cardiac muscles. The heart failure. In the heart failure, there is disease of myocytes, and if the myocytes are diseased, the contractility will be affected, and there will be decrease in contractility of the heart. The fourth determinant is the heart rate. Increased cardiac output under physiological conditions. It may be regulated by the sympathetic nervous system as well. They are also increased by the sympathomimetic drugs, and they are decreased by the beta blockers and the calcium channel blockers. The beta blockers and the calcium channel blockers, we talked it is a verapamil and deltazine. Here is a confusing diagram that is of the stroke volume and the heart rate. This diagram was demonstrated by an experiment in which the heart rate is increased, and by increasing the heart rate, the stroke volume will fall. That is, first here the heart rate was, let's suppose 60, and here it was, let's suppose 100. So at 60, the stroke volume was this much high, but at 100, the stroke volume was this much low. This is because this is a practical background, and this is because only the heart rate is increased in this experiment, and the contractility of the object on which the experiment was conducted does not rise. And because of that, the stroke volume decreases. But practically, this is not possible because when we increase the heart rate, with the heart rate, contractility is increased, and this contractility and the heart rate, they will eventually increase the stroke volume and eventually the cardiac output. So this is what, when the heart rate was studied against the cardiac output, so with the increase in heart rate, the cardiac output also increased. That is, the cardiac output is equal to stroke volume multiplied by heart rate. So stroke volume is increased with the heart rate because there is contractility of the muscles of the heart. Here is how the sympathetic nervous system under physiological conditions, the heart rate is increased and the contractility is increased. But we talked over here that in this experiment only the heart rate was increased, and with this increase in heart rate, the stroke volume was decreased. But practically, both the heart rate and the contractility are increased simultaneously, and it will increase the stroke volume. So stroke volume rises with increased heart rate. But here is a condition in which, with increase in heart rate, the cardiac output first increases and eventually it decreases. So in this condition in which the cardiac output decreases with increase in heart rate is a pathological condition. And that is the pathological heart rate when increase, it will cause the decrease in cardiac output. When does it occur? It occurs with arrhythmias. And arrhythmias, there is not a sufficient space for the ventricles to fill with the blood. And the heart is contracting too fast. That is, the heart rate is very high, and eventually the cardiac output will fall in such condition. This was one of the pathological conditions in which, with increase in heart rate beyond normal limits, it will decrease the cardiac output. Otherwise, in physiological conditions, with increase in heart rate, the stroke volume increases and eventually the cardiac output increases. And there was an experiment in which, with increase in heart rate, the stroke volume was decreased. But here in this experiment, only the heart rate was increased and the contractility of the heart was not increased. And in practical background, the heart rate and contractility are increased simultaneously, and it increases the stroke volume.